Right. Now let's talk about the uterus and the fallopian tubes. Okay. So, firstly, the weight. So, 6 grams. 60 grams. That is the average weight of the uterus. Remember, the ovary will be 6. Right? Okay. Then the blood supply is from the uterine artery, a branch of the internal iliac, and from the ovarian artery, like the anastomosis, right, with the uterine artery. This is coming from the abdominal aorta, right? And then these arteries are generally tutors. Why are they? Do they move in a coiled fashion? Why do they move in a coiled fashion? Right? Is because of giving allowance for stretching. So when the uterus enlarges, right, these blood vessels can easily stretch, right? Blood vessels can easily stretch, right, and then not even rupture. Okay, just like what we see with the facial artery, right? Now, for the venous drainage, they just follow the arteries. So for the veins, ovarian, veins, and then uterine. Right? And then lymph is into these areas. So number one, the internal iliac, a couple of lymph nodes. The para-aortic. So the para-aortic will be following what? The ovarian artery. Okay. And then with the superficial inguinal. Superficial inguinal will move with the round ligament of the uterus, right? Through the inguinal canal, right? So that's how it will pass lymph there, right? And then the sacral nodes. The sacral nodes are coming from the region of the cervix, right? So from the region of the cervix. And then we have the external iliac. That's all we in the external iliac as well. So we drain into the internal iliac as well as the external iliac nodes, right? The para-aortic, superficial inguinal, and then the sacral nodes, right? But the most common ones they asked about is the superficial inguinal nodes and then the para-aortic, right? They want you to, they want to test as if you know that the uterus also given blood from the ovarian artery, or the uterine. The uterus also has a communication with the labia majors, okay, where it gives lymph to the superficial inguinal nodes. Okay, so now the uterus in terms of structure, we know the structure, all right, and so let me just quickly jump to there. So generally that's the uterus. That's the uterus, and then from the uterus we have the uterine tubes. We have then the uterine tubes, not the fallopian tubes, right? And then remember I said that the infundibulum of the fallopian tubes is related laterally to the ovaries. Please. And then I'll start with the uterine tube. So there we have the fimbria, finger-like, which open into the peritoneal cavity, right? And then there we have the canal, right, for the fallopian tube, right? So we generally have the isthmus, right, for the fallopian tube, and then with the intramural part. The intramural part of fallopian tube is that part that we find at the opening, right? That is the isthmus over there, and that's the infundibulum of the fimbria, okay, right? And then most fertilization occurs in the isthmus, right? Then the intramural part, right, is just generally part of the intramural part.
Wow.
The intramural part is generally part of the okay. So then the uterus now is then divided into a fundus. So if I draw a line, like at the openings of the fallopian tubes, whatever is superior to that part, so this part, right? And then from there to the level of the internal os, that is the body. So that is the body. And then below, from the level of external os, right? What you actually see there is cervix, the vital part of the uterus, right? And then the cervix extends into the vagina, right? So the supravaginal cervix, cervix, and then by that fake, that's how we have these recesses that are called fornices. So that is the general shape of the uterus. And then remember, I said that the inferior pole of the ovary is connected to the lateral angles of the uterus by the ligament of the ovary. Right? So that's generally that. But before I move on to talk about anything else, may I just talk about the broad ligament? Right? May I just talk about the broad ligament? So the uterus generally is covered by peritoneum. So the uterus is covered by peritoneum, right? But what I actually see is that it's not all of the spaces or all the parts of the uterus that will be covered by peritoneum. So that is the uterus. You see that the anterior part or that part that is lying on the bladder, there is quick reflection of peritoneum, such that the anterior part of the cervix is in direct contact with the bladder. Okay. And then for the posterior part, that's when we say it extends even to the superior thirds of the vagina. Right. So that is generally a cross-sectional study. If we look at it anteriorly, right, what we see is that when it covers the uterus, it extends laterally. It actually extends laterally, that fold of peritoneum, right, to the lateral pelvic walls. So that ligament is what we call the broad ligament. So it should actually be two layers of peritoneum that we actually call the broad ligament, right? And then within this broad ligament, that's where we find structures within the broad ligament, right? So I want to make this clear. So we have the broad ligament, okay? So actually having the broad ligament, let me work it very well. So we actually have the broad ligament, right? That will be stretching to the lateral pelvic walls and then coming back. So remember, I said the level of the internal os. So actually be at the level of the internal os. So remember, I said the level of the internal os, right? So at the level of the internal os, right? So what I actually see is that below the level of the internal os, we have thickening, right? We actually have a thickening of fascia, thickening of pelvic fascia there, right? That will actually then call the parametrium. So that is what we call the parametrium. So don't confuse the parametrium with the perimetrium. Perimetrium is a layer that is formed by the broad ligament when it covers the uterus. So this thickening is what we call the parametrium, right? Remember, we talked about the parametrium in the past, in the previous tutorials there. So that is the broad ligament. So within the broad ligament, what you actually see are these structures. So within the broad ligament, what I actually see is the ovary, right? So there's the ovary, right, right. And then the ovary then, right, covered. So the ovary will be covered by peritoneum, right, right. And then it will actually be suspended, right, from the posterior parts of the broad ligament by this mesentery line that we call the meso-ovarium. So itself, the gonad is covered by peritoneum, right, but it's actually suspended, right, from the posterior. So if I say posterior, please pay attention there. Why? Because there are some questions where they ask you that the ovary is suspended, right, or is attached to the anterior surface of the broad ligament. No, remember the ovary is within the posterolateral areas of the pelvis. That means it has to be posterior to the broad ligament. Okay, so then I say if I look at it, if I look laterally, and then I look at this broad ligament, what I actually see is that posteriorly we have the ovary covered by peritoneum. And then this peritoneum will continue and then continue with the layers of the broad ligament. So that is your ovary, right? That is the ovary there. And that's the germinal epithelium, right? That will then continue as the mesovarium there, right? So that means the ovary is in there, right? Within the broad ligament, right? We find that the fallopian tubes, right? So the fallopian tubes are moving on the upper part of the broad ligament. So they're also covered. So this broad ligament will go up and then cover the fallopian tubes. Actually then cover the fallopian tubes. Okay, right? But something of interest now is that as we see that from the angles of the uterus, the inferior pole, we have the ligament of the ovary. The ligament of the ovary as well is within. So the ligament of the ovary is also within the broad ligament. So if questions come, MCQs come, the ligament of ovary is also within the broad ligament, right? We actually see that the part that is between the ligament of the ovary, right? So the part of this broad ligament that stretches upwards from this ligament of the ovary to encircle, right? To encircle, just like that, to encircle, just to encircle the fallopian tubes. is what we call the mesosalpinx. It's also called the mesosalpinx. The mesosalpinx. Right? Right. So then this lower part is then generally called the broad ligament of the uterus. So the broad ligament of the uterus, the mesosalpinx, the mesoovarium, right? We should see that from the lateral pelvic walls, we also have got fascia that extends right to the ovary that we call the suspensory ligament of the ovary. So that's part of the mesentery. Now, not actually mesentery, but actually we can say mesentery that is connecting the ovary to the lateral pelvic walls, and then the mesentery that connects the ovary to the posterior part of the broad ligament. That's called the mesoovarium. And then we said the mesentery that connects the ovary to the lateral pelvic wall. That is called the suspensory ligament of the ovary. That's where we have passage of the neurovascular structures of the ovary. All right. So that is the information I can tell you about the broad ligament. And then another component as well of the broad ligament are the remnants of the mesoovarium, not the mesoovarium, I mustn't forget the structure that we talked about in embryology today, that will leave the parophron, right, and the epirophron. These words just run away from me, right? Right, the parophron and the epirophron are also components of, or generally are also within the broad ligament. Then we also see the uterine artery. So the uterine artery, like being a branch of the internal iliac, right, will first move within the parametrium. And then at the level of the internal os, right, move within the broad ligament. Broad ligament, right, when it crosses on top of the ureter there. Right. So that is the information that I can tell you about the broad ligament, right? So then the support of the uterus, right? So the uterus needs support. So the first support is the levator ani. We talked about this. That means tearing of this muscle leads to prolapse, right? Prolapse of the uterus, right? And then the perineal body, right? Why? Because the perineal body is this attachment or the insertion of many of the muscles of the levator ani, right? That means if you paralyze that one, also you've got prolapse of the uterus, right? And then we've got thickenings of fascia that we talked about in the previous tutorials. That called from the pubis cervical, from the sacral region, the sacrocervical, and then from the ischium, we have this transverse cervical ligament, or what we call the cardinal ligaments. Right, right. Remember, now the weight has come back. That's called the mesonephric duct. So the remnants of the mesonephric duct, which is the epirophron and the parophron, are within the broad ligament. Okay, then now, number 4 is, so for number 1 to 3, these are the strong supports. Please get that. These are the strong supports. Okay. Number 4, these are the weak supports. So they play a minor role. Who are these guys? The broad ligament and the round ligament of the uterus. That means this guy, this broad ligament, and the round ligament of the uterus that will come from here and then go on and then attach to the labia majora, right? That ligament, it's actually laxed. They are also lax. So the round ligament of the uterus and then the broad ligament, these are lax structures. So when the uterus enlarges during pregnancy and then comes back to normal, these structures will actually be straight, right? Actually be distended, right? So they play a minor role in support of the uterus. So remember, I said the broad ligament and the round ligaments play a minor role in support, right? Due to their laxity, right? And then uterus. So when the uterus prolapses, right, it's always associated with the vaginal prolapse because these structures are attached. Yeah. So whenever this guy, descends downwards, what happens? The vagina also descends downwards, so that we see that the mucosa of the vagina, right, can actually prolapse outside. The mucosa of the vagina can actually prolapse outside like that, and then the uterus actually descends, right? And then in terms of the arrangement, right, how we see the uterus, the common one now is this structure. where the uterus is what called the anteverted position. So you see, that is the axis for the uterus, right? That is the axis for the uterus, and then that is the axis for the vagina, right? So that is just the long axis of the vagina and the long axis of the uterus. So you see that there is actually an angle over there, right? That's called the angle of anteversion, right? So we actually say that when we have the axis of the vagina, right, and then the axis of the uterus goes anteriorly like that, and then we have this angle of anteversion, right? This angle of anteversion over there, right? This is what called anteversion, right? Anteversion position. Right? So that's called anteversion. So remember, anteversion includes what? The vagina and the axis, right, of the uterus. Specifically, what I can actually say the axis of the cervix, right? The second thing that we also can see is this feature, whereby, so generally that is the axis of of, so let me just draw that. That is the axis of the cervix, right? So if the body of the uterus is also in the same axis, the only thing that we have there is anteversion, right? But sometimes at this point where the body of the uterus starts, we can actually see that the body of the uterus will also bend as well, right? Will also bend, right? So that we actually say that when the body of the uterus bends forward, right, we have now two axes. One axis continues there, that is the axis for the cervix, and then another axis there is now the axis for the body of the uterus. That is now what we call anteflexion. What we call anteflexion. That is exactly what we call anteflexion. So let me put out this point and then you can actually see what I'm talking about. Right? Anteflexion. So this is what I'm saying. Um, Here we have the axis of the vagina there, right? And then here with the axis of the cervix. So that is anteversion. So that's the axis of the cervix going forward, going superior like that, right? And then the body of the uterus also bends at the level of the internal os, right? So that's the level of the internal os, right? So when it bends forward, now the body of the uterus, that is now what we call anteflexion, anteflexion, right? So anteflexion involves what? The axis of the cervix and then the axis of the body of the uterus. That is anteflexion. Anteversion involves the axis of the vagina and the axis of the cervix. You don't have to worry about the ankles. Right. Then the opposite of that can also happen. Retro. Right. So you can have retroversion where the body of the uterus as well as the cervix are within the rectal, the pouch of that right there. The rectal uterine pouch, the pouch of that. And that normally happens when one has pregnancy and the uterus goes up. So when it comes down, because now the ligaments that keep the uterus in this anteverted position, which are the mainly this ligament, the round ligament of the uterus, now it's slack. So it's slack. That means the body can actually then rest in the opposite direction. That's easy, right? Okay. Laxity of the round ligament of the uterus causes retroversion, right? So you have retroflexion. Okay, right. So I want you to remember that the anteflexion occurs at the level of the internal organs, right? And that is generally revision for the lymph drainage, right? We say that we have the external iliac nodes, and then with the internal iliac nodes, right? Internal iliac nodes over there, and then at the sacral nodes from the region of the cervix, right? Sacral nodes from the region of the cervix. That means that if you've got cancer at this point, we know where to track it, right? We know where to track it. And then we have the superficial inguinal nodes, right, coming with the round ligament of the uterus, ligament of the uterus, and then the para-aortic because of the anastomosis that we find between the blood supply of the ovary. So actually you have the ovarian artery coming there and then anastomosing with the uterine artery there. And then both of them actually supply the uterus as well as the fallopian tube. So the fallopian tubes of the uterus, they get dual supply. Okay, right. And you actually see that if we increase in pressure within the uterine artery, we actually see that that blood also supplies the ovary as well. Right. Fine. So that is with the pelvic organs that I had to look at the major pelvic organs. But now let's move on to perineal, and then we'll quickly go through these features which are very important for us, specific exam. Um, Lymph drainage, the anal canal, the sensory supply, the ischiorectal fossa, extravasation of urine, as well as the pouches. Right. So if we look, I want to just start with this, the sensory supply, so that we don't waste time. So with the sensory supply, what I actually see is that I want to look specifically with the region of the pudendal region, right? The pudendal region. So I'll look within the males, right? So if I look at the within the males, right? So within the males, there is the scrotum, right? Then there's the testicle there. Then within the females, what I actually have is the labia majors, right? So two labia majors there. Now let's talk about the sensory supply. So with the sensory supply, we will divide these structures into anterior parts and then posterior parts. All right, anterior parts and then posterior parts. So for the scrotum, if I cut it, right, trying to select that, the skin that is anterior, right, the skin that is the anterior part of the scrotum are supplied by two nerves, right? Are supplied by two nerves, right? They're actually supplied by two nerves, right? The genitofemoral nerve, right, and then the ilioinguinal nerve. The genitofemoral nerve and the ilioinguinal nerve, right? The genitofemoral nerve and the ilioinguinal nerve as well, right? Also, we can get sensory supply coming from the perineal branch of the internal pudendal, not the internal, but the pudendal nerve, right? Okay. Then the posterior part. Posterior part is supplied by the posterior cutaneous nerve of the thigh. The posterior part is supplied by the posterior cutaneous nerve of the thigh. Right. So remember, I say anteriorly. Anteriorly, we have supply from the pudendal nerve, right, and then the ilio inguinal nerve, right. And then for the labia, so if I cut them as well, so if I, now we're looking anteriorly, so that is the orifice, right, that is the valve, and then I cut like that. What I see that is the skin anteriorly, right, is also supplied by the pudendal nerve, right, the pudendal nerve, and then also the ilioinguinal nerve, right. And then posteriorly, right, that skin is supplied by the posterior cutaneous nerve of the posterior cutaneous nerve of the thigh. That's very, very important. That's all about the central supply that I can talk about. And then the major nerve of the perineal region is the internal, not the internal, the pudendal nerve. And then in the previous discussion, we talked about this nerve coming from S2 to S4. Okay, S2 to S4. And then, so that is with the sensory supply. The questions they usually answer about the sensory supply. Okay, fine. Then about the lymph drainage. The lymph drainage. So for the lymph drainage, for the skin, so the lymph drainage, generally for the skin, that's the major question that comes. That goes to the what we call the medial group of the superficial inguinal lymph nodes. So the medial group of the superficial inguinal nodes. Okay, that's about the lymph drainage. And then I'll talk about the anal canal later on, and then the ischiorectal fossa, and then that. But now we are clear for the sensory supply and the lymph drainage. Okay, right. So the region of the perineum, right, is generally divided into two main regions, right, by a line that is drawn between the two ischiopubic right, that we say anteriorly, right, with this ischiopubic rami, what we see is this area that we call the urogenital triangle where we have the genitals. And then within the posterior part, right, bounded by the ischiopubic, the tip of the process, and then laterally by the sacrotuberous ligament. What I actually see is the anal triangle where we have the anal canal. Right? Now we clear it. And then lateral to the anal canal, we have this space that will actually be filled with fat, right? The space that will actually be filled with space, right? That's what called the ischio ischiorectal fossa. So that space is what called the ischiorectal fossa. That is called fat, right? And then one clinical that we have to talk about before I move anywhere is that if you've got infection within the fat, because this fat is poly supplied with blood, so there's infection there, right? So there's high chances of infection that is moving from the rectum or the anal canal. That infection can actually cross to the opposite ischiorectal fossa, posterior to the anal canal. Please, I said posterior to the anal canal. There is no entrance anterior. So these two spaces communicate posterior, right? That's cool, right? And then now we talk about the pouches. So then that is the pelvis. So that's the pelvis, right? And then remember the pelvis is separated from the perineum, right, by the urogenital diaphragm. So that is generally the urogenital diaphragm over there. And this urogenital diaphragm, right, what we actually see is that components of the urogenital diaphragm, what we can actually see within the urogenital diaphragm, that is what we call the deep perineal pouch. So what we see within the urogenital diaphragm is what we call the deep perineal pouch. And remember the superficial fascia, how we divide the superficial fascia into a fatty layer if it's for the abdomen, a fatty layer, and then a membranous layer, the scapus fascia. This scapus fascia within the region of the perineum, right, is now called the Colles fascia. And if you look at the Colles fascia, what I actually see is that this Colles fascia, so from the anterior abdominal wall, we have this fascia extending, right, to cover the penis. That is what's called the Barks fascia. So they to be called the Barks fascia. So that's the Barks fascia. And then at this point is now being called the Colles fascia, and then being a component of the scrotum. And then it extends posteriorly to attach on the perineal body. So there we are. We have the deep perineal pouch over there, right? The superior boundary of the deep perineal pouch is this. Remember when we talk about the parietal layer of the pelvic fascia, that fascia, that thickened fascia over there. And then inferiorly also that fascia also thickened. But the inferior fascia, right, this inferior fascia is what we call the perineal membrane. So the inferior fascia is what we call the perineal membrane. So it is given this special name, the perineal membrane. So that we say that separating the deep perineal pouch and then the superficial perineal pouch is the perineal membrane. How it together is the perineal membrane. And then between the symphysis pubis, so this urogenital diaphragm doesn't stretch to the symphysis pubis, right? Because it has got attachments on the bodies of the pubis. So it is attachment on the bodies of the pubis. So there's a space that actually be left there for the passage of the dorsal vein of the penis, the dorsal artery of the penis, the dorsal nerve of the penis, as well as the clitoris, just passing at that point, right? So cool. So what then do we see? What then do we see? That the structures below the the perineal membrane, the structures below the perineal membrane are all within the superficial perineum. That means the root, right, the bulb of the penis, right, as well as the crura, the bulb of the penis as well as the crura are within the superficial perineal pouch, as well as their muscles, right? The bulb spongiosus and then the ischiocavernosus are also within the superficial perineal pouch. Their nerve supply, right? That is the pudendal nerve. The nerve supply, the perineal branch of the pudendal nerve, right? And then also the scrotal nerves are also within the superficial perineal pouch, right? And then actually see that what the gonad, yes, is there. The gonad is also there, right? So everything that is bounded, right, below the perineal membrane and then above the Colles fascia, right, is within the superficial perineal pouch, right? So then the root of the penis, and the penis that go outside it. So what's the importance of this is the importance is when we talk about extravasation of urine. So that means, let's say you're trying to, you know, pass a catheter, right, within the prostate, the urethra over here. So you're trying to negotiate that bend, and then you know, injure the prostate, the urethra over there, the injure the urethra. So what you actually see is that there is hemorrhage, yes, and then urine will actually pass. So urine will actually pass out into the superficial perineal pouch. Superficial. So urine actually pass into the superficial perineal pouch. So extravasation of urine from the penile urethra. Where does it go? That is the MCQ, right? It will go into everything like this: the scrotum, right? The scrotum, the penis, that we go to the penis, and then the anterior abdominal wall. The anterior abdominal wall. Those are the regions only. If they, ask about the ischiorectal fossa, no, that's false. If they ask about anal canal or what, that's false. Why? Because we say the posterior boundary is the perineal body. Right? Then extravasation of urine from this membranous urethra, what I can see is that there's only limited flow into this deep perineal pouch. That's interesting, right? Only the deep perineal pouch, right? So those are the components in the males that I've actually talked about, right? And then other components that I actually see is when we talk about the dorsal. So this dorsal vein of the penis, dorsal artery, dorsal nerve, right? They actually be moving within the deep perineal pouch and exit and then go the dorsal on the penis. The nerve, the artery, right? That means that whenever we talk about the dorsal nerve or artery of the penis or the clitoris, what you see is that they are components of the deep perineal pouch, right? Then we've got two important muscles, right? One muscle is found within the deep perineal pouch. One muscle is seen within the superficial perineal pouch, just below the perineal membrane. These are the transverse muscles that are moving from the ischiotuberosities as well as the ischiorhammus, right? So the deep transverse perineal muscle, is a component of the deep perineal pouch, and then the superficial transverse perineal muscle is a component of the superficial perineal pouch. All right, that's interesting, right? And then generally that is the vulva, right, or the pudendum for the females. All these components are within the superficial perineal pouch for the females, right? That means the bulb of the vestibule and then the cooler of the clitoris, right, as well as the greater vestibular glands in their ducts. Okay, they're also within the superficial perineal pouch. And then the muscles, the ischiocaphenosus and the bulbus conjunctus, they are within the superficial perineal pouch. That's the cross section now for the males. For the males, what I actually see is that we have this membranous urethra within the deep, and then there it gets into the bulb, right, of the penis, right? The bulb of the penis over there, right? And then this bulb is covered by the bulbus conjunctus, right? Fine. And then that is the crura of the penis covered by the ischiocaphenosus over there. So all these are within the structure of the perineal pouch, right? And remember, that's our dorsal neurovascular structures for the penis, right? They're also within the perineal pouch. Right? And then one structure I want us to put our focus on is these bulbourethral glands. The bulbourethral glands are located within the deep perineal pouch. Although they are analogues with the greater vestibular gland in the female, but for the greater vestibular glands in the females, they are within the superficial perineal pouch. Very, very important. But the ducts for these glands are the ones that we see within the superficial perineal pouch. So if questions come, just analyze clearly. Did they say the gland only, or did they say the duct? The duct is within the superficial perineal pouch. The gland is in the deep perineal pouch. Okay, and these are the perineal branches or the scrotal branches for the pudental nerve. Okay, within the superficial perineal pouch. And extravasation of urine is limited laterally by the ischiopubic rami, inferiorly by the colles fascia, superiorly by the perineal membrane. So there we have urine limited there. Right. And that is for the females on black and white, right? So what you can see within the superficial perineal pouch. So this is the colles fascia, that's the colles fascia, and that is the perineal membrane. All right, so what you can see is that's the bulb, right? And then that is the cooler for the clitoris. And then there are muscles, right? Also within the superficial perineal pouch, right? And then these are the dorsal nerves and arteries, right, for the clitoris, right? They are within the deep perineal pouch, but there's no gland. The glands, the greater vestibular glands, and their ducts are within the superficial perineal pouch. Now, which get yes, and if they ask questions concerning these structures, not within the superficial perineal pouch, right? Yes, they are within the fatty, right? So the actually these are fatty structures. Okay. And we talked about the deep transverse perineal muscle within the deep perineal pouch and then the superficial transverse perineal muscles coming from the ischiopubic and as well as the tuberosities. Okay, right. So that is generally a revision for the pouches for the females and then for the males. Right. So you go through this picture when you then do the revision and then you rewatch the video. Okay. ischiorectal fossa, now this is a space that is located lateral to the anal canal, right? And these are the borders. We have the levator ani muscle. So remember, it's going to the external sphincter, the upper part of the external sphincter there. And then here we say it attaches on the obturator fascia, right? And then here what we see is the obturator fascia as well as the obturator internus, right? So that forms the lateral boundary. And then the superior medial is the levator ani. And then the inferior part, that is the skin. That's the skin. So this region is then filled with fat. But importantly is that lateral. So remember what I said. Lateral within this ischiorectal fossa is the pudendal canal. Please, I said lateral, not medial. It's located lateral, right? And then I said the ischiorectal fossa of one side and the other side communicate posterior to the anal canal, not anterior. Because anterior there is this dense fascia, which is the perineal body. Right. So that is the pudendal canal there with the pudendal vessels. So that is generally the mid-rectal artery, not the mid-rectal artery, sorry, the inferior rectal artery, right, running to that structure over there, right. And then for so this just cover there, over there, right. Hold on this, right. So we have then the pudendal nerve over there, right, and then the dorsal nerve of the penis over there as well, right. So this is for the ischiorectal fossa. So anything they can ask about is how you can palpate the eccentric velocities, right? How you can actually palpate the eccentric velocities, and then the movement of infection from one side to the other side, and then the position we find the pudendal canal. Okay, so that is with the ischiorectal fossa. And then the anal canal, what I can say here is, which is with time quickly, is the very important stuff is the division, where we have the pectinate line dividing the upper part of the anal canal and then the lower part of the anal canal. What I can say is that the blood vessels, the nerves for the lower part of the anal canal is somatic. The blood vessels and the nerves for the upper part of the anal canal is visceral. That means the somatic nerves, they sensitive to stretch. Here with the visceral nerves, sorry, the autonomic nerves, and here with the somatic nerves, sensitive to pain and touch. Okay, and then that is divided by the pectinate line. And then the upper part is with these anal columns, anal columns, anal columns, anal columns. We cannot see that over here. That's number one. Number two is the presence of two types of sphincters: the internal sphincter, right, and then the external sphincter. The external sphincter being motor, somatic, and then the internal sphincter being autonomic. The internal sphincter is generally thickening of what? The longitudinal layers as well as the midocircular layers of the gut tube, right? And then this external sphincters are then divided into what? Number one, subcutaneous, within the subcutaneous layer, right? And then the superficial, that is the only sphincter that is with a bony attachment, right? And then the deep one. Remember, the deep one is the one, the deep part of the external anal sphincter is the one that is tethered to the pubal rectalis. That is the important information concerning anal canal. Everything about what line, that has got no use for now. Okay, so that is generally the perineum, friends. So we keep the time because our Zoom, has got limited time. So generally, that is what I can say for today, right? So let's go and look at this region